So the next session would be the next level on non-surgical lifting. Of course, that it will be a combination treatment, both face and neck. And we have a four speaker with us. First of all, I would like to start with Dr. Park Min Jae. He is the plastic surgeon from Korea. Yes, this stage is yours.
Good afternoon, everyone. Okay. Thank you. Good afternoon, everyone. I am Dr. Min Jae Park from South Korea. Okay. Oh, that is not my PPT. There's a morning session, afternoon session. Please change. Okay.
So your talk will be about the layer biostimulation,
okay.
right? For the mid phase.
Not this two PPT, not this one. There was some confusion in the morning session also. Next, this is not the morning session. No, because I saw my PPT and morning session. That also in the morning, the session was afternoon session presentation was presented. Okay, so
ผิดชุดหรือเปล่าครับ
this one, okay, exactly. Yeah. But the topic is different. Oh my gosh.
Maybe we have to fix it first, right?
Okay.
So sorry, Dr. Min Jae. Maybe I will switch to you first, Dr. Terry. Okay. Yes, and during this time, our staff will work on your presentation, Dr. Park. All right. So yes, I would like to move on to Dr. Terry Yan. So Dr. Terry will present about the V-shaping with multi modalities with injectables and also the RF microneedle. Yes.
Okay. Oh, yes.
Please, don't worry. Yes.
I was in another session. I just finished.
Hi, everyone. I'm Dr. Terry Yan. It's a pleasure to be here in INCAS Bangkok. Today, I would like to share my clinical appearance of Asian V-shaping with my technique focused on face and neck rejuvenation. I'm Dr. Terry Yan. I am both certified plastic surgeon and currently based in Shanghai and Beijing and practice there. I was fortunately to receive guidance with Dr. Jeffrey Klein, the dermatologist. My clinical focus is on injectables, energy-based device, and minimal invasive Asian rejuvenation. Quick disclosure, I have no financial interest related to the content today. Okay, let's start with something lighter. In Asia, if someone tells you your face is so small, that's a
great
huge compliment. But if you say the same thing to the Western people, they might think, wait, are you making fun of me? And across over the world, like no matter in China, Korea, Japan, India, or Thailand, everyone have a same pose, hand under the chin, and they immediately make your face look smaller. That brings us the topic today. How can we make a face to look smaller, tighter, and more better contour? So, a V-shaped face is a structural equation. It's not just a narrow chin. It has four variables: skeletal projection, soft tissue distribution, envelope quality, and the downward factor. A point chin without low reduction or tissue support may worsen and further weigh down the face, while leaving the jawline poorly defined. So, before the visible jawline output 5 interacting layer, just like we doing injection, we must know which layer is falling. Before choosing a device, diagnosis the layer is the most important. We have to assess is the skin texture, or elasticity, or collagen density, thickness at the dermis, fat in the subcutaneous, and mobility, downward pull at the smooth layer, and the bone projection, skeletal projection. Combination treatment is only justified when one more layer is causally relevant. And we have to ask 4 questions. Is the face width because of the structure? Is the subdermal fullness superficial or deep? If the tissue mobile enough to reposition, to redrape, can the skin envelope capable of redraping? I know it's our section is minimum invasive and injectable section, so I'm not going to cover the surgical part. And fusion is not just procedure staking. Fusion works only when each modality has one distinct job. So before we start to treat assign one discharge to each modality, we must know injectable radiofrequency treat deep soft tissue envelope and select subcutaneous access. Radiofrequency microneedling, on the other hand, remodel the dermis and superficial fat layer. And filler restore projection and contour transitions. Thread reposition the mobile tissue. Overlap is not synergy. True synergy comes from the understanding of the role and the limitation of each modality. So let's break it down. What does each treatment actually do, and how should we sequence them in a rational manner? So first, talk about injectable radiofrequency. It basically is a tissue tightening device, and you can treat with adipose tissue. For those of you who are not familiar with this device, think of it's a minimum invasive subdermis radiofrequency system. The energy delivered through microcannula with real-time thermal monitoring. And its role is not just male fat, as I just said. Its real volume, its value, it's to contract the skin and soft tissue envelope, cause the fibroseptal network contraction. And as you can see, with this device, you can control the fibroseptal network and selective adipose reduction. That's our first modality. And the second modality is radiofrequency microneedling. It can remodel the dermal soft tissue envelope and through outside-in energy delivery. The first modality is injectable RF. It's inside out, and this one is outside in. And it works better with fine skin elasticity and minimum adiposity, early joint, creepy skin, and so on. And it can also improve skin redraping capacity before mechanical support. And the third modality is filler. Everyone loves filler, but it causes a lot of trouble nowadays. Filler, we should use filler first when the bone skeleton deficiency is our first problem, especially in the Asian patient, because as you know, Asian patients are lack of projection. So if the patient have retrude chin, we can use filler first. But if a patient with a lot of fillers, you use filler to treat every problem, it causes facial over syndrome. It may get worse. And filler builds, as I just mentioned, filler builds skeletal anchor, transition, not bulk. For Asian patient, the difference between West and East, Western like a really angular jawline and sharp jawline, just like a marker pen. But East Asian people, we prefer oval, smoother contour. So the softness and harmony is what Asian pursue nowadays. And you cannot just use Western method to address Asian jawline. It may cause, it may get worse. And it's obvious like a facial overfilling syndrome. In Asian, less is more. And for thread reposition mobile tissue, they cannot correct heavy lower face. So before you using thread, you must know you have to assess the whole face and check the tissue behavior. If a tissue is too heavy, thread is not working. So thread reposition mobile tissue, but they cannot correct heavy lower face. So you should keep it as the less modality, in my opinion. So this is my Asian V shaping sequencing protocol. First, we must diagnose the falling layer, and then with the assess of skeletal deficiency, we first establish the skeletal anchor, refine the projection, and then we use contract and debug device like injectable radiofrequency or radiofrequency microneedling. And then after that, we enhance the capability of the draping capacity. We can use thread to give you a factor. And then lastly, we can use filler to refine the chin to project area to the mandibular angle area to refine the transitions. So let's see some case. As you can see, these are quite common facial shape in China. And a lot of patients, she want to have oval contour. Also, she did default surgery, but she had a really boxy face. And after the protocol I just mentioned, I use radiofrequency microneedling with injectable radiofrequency and then thread and then refine the contour. As you can see, her jawline become really smooth. And this one, she's a young female, so I only use the microneedling and then use thread and use filler to refine her contour. And not just women want V-shaped face, and a lot of men keep their beard because their jawlines disappear. So with the same maneuver, with the same sequencing protocol, you can get a nice chisel jawline for men. And for this kind of case, she had a chin retrusion. We must first to establish the bone anchor and then use the same sequencing, and you can get a nice result. And this one is similar. It's look like she need a lot of filler, but don't do that. You can use first to contract the soft tissue envelope, and you can use lace filler to treat this kind of case. And this one is the similar one. I will not cover too much. And that's one with this kind of face. She did Botox as well, and I use a filler and then radiofrequency microneedling and use thread as a factor. As you can see, she got her V-shaped face. And that's one similar maneuver, radiofrequency microneedling, filler, and thread as a finisher. So that's what is take-home message. Fusion is not more treatment. It's less redundancy, better timing, and cleaner anatomical reasoning. Fusion doesn't mean procedural staking. You must diagnose the falling layer and use the right sequencing and get the better result. Thank you for your attention.
Thank you so much, Dr. Yan.
Now we'll call upon our next speaker, Dr. Park. Dr. Park is an anti-aging specialist and a cosmetic surgeon from Busan, South Korea. He is the founder and president of the World Aesthetic Anti-Aging Society. Welcome.
Okay, thank you so much. I really appreciate it. Okay, good afternoon, everyone. I'm Dr. Minja Park from South Korea. Okay, and today I'd like to share and I'd like to introduce a protocol-driven regenerative approach called layer biostimulation or LBS. This is a reproducible three-layer algorithm designed for the mid-phase rejuvenation, moving beyond traditional volume replacement toward true biological rejuvenation. Okay. Filler. The filler paradigm, the hyaluronic acid filler remain one of the most commonly performed aesthetic procedures worldwide. However, fillers mainly provide volume. they occupy space, but they do not activate cells, stimulate regeneration, or restore aging tissues. Okay. As a result, patients commonly often become dependent on repeated treatment. Okay, limitation. Okay. Limitation we see in practice are familiar. First, filler do not regenerate tissue. Second, complications such as vascular occlusion, migration, and Tyndall effect remain concerns. Third, excessive volume can lead to unnatural outcomes such as the so-called filler phase. These are not product failure. I think that they are protocol failure. Next one. So, aging is much more than volume loss. Collagen production declines. ECM, extracellular matrix, becomes degraded. PET compartment atrophy, ligament loosen. The phase ages across multiple tissue layers simultaneously. Therefore, single-layer solution cannot fully address multi-layer problem. So we need to change. This leads us a new paradigm. Instead of replacing lost volume, we should stimulate regeneration. The goal is to activate fibroblast, restore the extracellular matrix integrity, and reveal tissue from within. In other words, we should treat biology as aging rather than simply its appearance. Next one, LBS. LBS stands for Real Biostimulation Sequencing. It is structural protocol that targets three distinct anatomical layers of the midface. Each layer has specific biological target and specific product category and specific regenerative endpoint. This creates a reproducible and standardized treatment algorithm. Midface, okay, there is midface anatomy. Midface can be divided into three major layers. The superficial layer is responsible for hydration and skin quality, and dermal layer is primarily collagen-producing zone. And deep layer provides structural support and projection. Understanding these layers is essential for rational treatment planning. LBS protocol follows an inside-out approach. We begin with the deep structural restoration. Then we activate the dermis. Finally, we optimize superficial layers. Next one. Then, precise depth control is critical. Even small deviation in injection depth can place the product into the wrong biological compartment and reduce efficacy. Cannula strategy. Safety and precision are fundamental. Blunt cannula are preferred for the deep and mid-level. Treatment and microneedle are used for superficial delivery and skin quality improvement. Each instrument is selected according to the anatomical goals. Deep structural restoration. The first layer focuses on the deep structural support, and we have to focus on the first layer to focus on the deep structural support, and targets include the deep medial check fat compartment, SOOF, and periosteum. Next one, okay. Products such as calcium HA and PLLA provide scaffolding and stimulate regenerative response. Deep layer, okay. Layer, second dermal action, second layer targets the reticular dermis where the fibroblast actively produce collagen. Okay, all doctors know about this, okay? And this is true biological engine of facial rejuvenation. And next one, PLLA stimulate collagen production through the macrophage-mediated signaling. Diluted calcium HA directly activate fibroblast. Next one. Histological studies demonstrate a significant increase in collagen density and improvement of fibril organization following treatment. Rear scan. Superficial optimizing, third layer focus on the skin quality. At this level, we target hydration, barrier function, and luminosity. Polynucleotide support this repair and cellular signaling. The rear enhances the visual regenerate, the deeper regenerative process. Ultrasound. Okay, one of the strengths of this protocol is objective evaluation. Using high-frequency ultrasound, we can monitor changes in the dermal thickness and echogenicity over time. And 3 and 6 months, we frequently observe the measurable increase in dermal density and thickness, reflecting new collagen formation. Case, clinical case, she is, okay, my hospital nurse, okay. The patient was a 55-year-old woman with mid-face volume loss, skin elasticity, and deep nasolabial fold. After the complement LDS protocol, we observed the restoration, malar projection, improved control, and measurable dermal thickening at 6 months. This demonstrates how structural and biological regeneration can work together. Okay, the second patient was younger and primary concern with the skin quality. In this case, we emphasize the dermal and the superficial layers rather than the deep volumizing. Okay, and after 3 months, skin texture and luminosity and hydration improved significantly with the measurable reduction in transepidermal water loss. Okay, take-home message. There are 3 key messages. First, regeneration is more important than simply adding volume with filler, okay? Second, the facial aging occurs in multiple layers and therefore require a layer treatment strategy. And third, protocol improve the reproducibility and allow consistent clinical outcomes across the practitioners. Okay. Okay, thank you so much.
Thank
your
you
attention.
so much,
Okay.
Dr. Park. Thank you. So very insightful lectures about layer by layer in detail. So don't forget, if you have any questions, just you can type it down in our application and it will really shows here. And we can do the Q&A at the end of the presentation. Thank you. So next we have Dr. Pupor Dagne from Spain. She will talk about multimodalities with neck rejuvenation.
Thank you very much. Let me try to put here. So this is a very personal topic for me because I feel more like a turkey neck since I was very young and before I knew about aesthetic treatments. And it was same for a kid that during the dinner with friends. And since that day, the neck became a big concern for me. I'm Dr. Pupo. I'm coming from Palma de Mallorca, Spain. And I want to share with you what is the algorithm that I use in all my patients when they come to the consultation because they feel that they have an aged neck. What is a yaw neck? If we think about it, it's a defined mandibular ridge. It's when you have absence of jaw, so it starts with the lower third. We have infrahyoid depression in the area. We have a visible thyroid cartilage. We have a cervical mental angle degree that is between 150 and 120 degrees. And we have a defined sternocleidomastoidea rim. So that is a yaw neck. But what happened with age? The patient is whatever they concern is what they see. But we need to think about what is happening inside the patient. So the patient can see that they have a creepy skin. And we know that it's a skin quality loss. And that's come because the UV photoaging and intrinsic aging. Next, they have skin laxity, and that happens because we have ACM degradation and we have ligament laxity, and that is because we have a structural failure in the area. We have the double chin, and that is because we have fat resorption and bone resorption. So that constitutes a volumetric change for us. What else we have? We have platysma band in the area, and that is conferred the hyperactivity of the platysma, and that is a dynamic aging that we have here. And the horizontal necklines, the one that I have since I was a kid, this is a repeat flexion in the area, but sometimes people like me, we have it like a genetic, and it's a mechanical imprint that we have here. And they accelerate aging, that is because the exposome and the gravity time, that is a systemic acceleration aging process on the neck. So the transformation of the neck occurs in these layers. Skin, we have elasticity, loose skin rigidness, we have platysma, adiposity. We need to think about the lower third all the time when we are treating the neck, and the digastric muscle. That is very important when we are looking at this area. So I wish that would be so simple that we can just tie the skin on the back and do it like that and send the patients back at home. But it's not so simple like that. So I like to systematize my classification in my daily practice, and how I do it is I classify my patient, grade 0, 1, 2, 3, and 4. And how I do this? I think about all the characteristics that we talked before. This is the evaluation criteria and patient selection. The first, jowls, laxity, rest platysmus band, active platysmus band, fat pad redistribution, perioral aging, oral commissure mandibular angle. And depending on this, I give a grade to my patients, and that is how I'm going to plan the treatment. But we have any non-surgical solution for this area. This exists. If we think about that, we can track with different treatments, as my colleagues talked before, different layers, skin, subcutaneous fat, platysma, and the gastric muscles as well. And we can go in each layer with different kind of treatments and options. But this is the algorithm that is already published. It's the algorithm for the neck treatment. And in here, algorithm is going to make us clinical practice more easy for all of us. So we have a patient that have a volume reduction, that is a patient that needs volume replacement, and a patient that needs a skin tightening. And when the patient arrives to the clinics, I need to think about it. What is the first that we're going to do? The first is volume reduction. The options that I have, if I can combine, or I need to wait of them, so the patient that needs volume replacement and the patient that needs a skin tightness. So this is a flow chart, depending on the classification that we did on the patient, how we can do it, how much we need to wait, how to combine, what is first, what is next. This made our work very easy for us and for our team as well, no? So we need to know what we are targeting in the area and how we can do that. Talking about the techniques and treatment protocols that we have, it's important that we understand that each one of them has different sessions, needs different time, recovery, maintenance, combined session, and duration. I will say that I mark here combined session lipolytics, because lipolytics, we need to think about, we can combine, yes, but if you are doing in the jaw and submental area, yes, because you can do then the neck, and you can combine neuromodulator, but always as the last part of the treatment. And how many sessions we need, how many times we need to wait to see the result, recovery time, and this is important because this is about patient expectations, and we need to manage the patient expectation in our daily practice. Let me show you a grade 2 neck, and how we combine the treatments. In this one, we see that the patient has pre-jaw. He's a 56 years old patient, and in this area, the patient comes from above, so she's coming to Mallorca, and we are going to do the lipolytic in the jaws. We are going to combine with radiofrequency with microneedling, polynucleotides on the same area, and then we do PLLA on the neck and the patient. And so we can do at the end of the treatment the neuromodulator. So this is a multimodal approach, all done in just one session, because we can combine treating all the different characteristics that we see before that the patient needs for a jaw, neck, lower third, submental area, and also the skin at the neck. So this is important because the reasons that when the patients come to the clinic, they have dissatisfaction of the treatment, they're dissatisfied of the treatment, is because we have a very bad, sometimes, patient selection. Sometimes we start doing one radiofrequency with microneedling at the patient, or we start with ultrasound. It's not what the patient needs. So this is important, the classification. Poor correction of the double chin late nodules, that late onset nodules, nerve injury, and don't affect the platysmus band because sometimes we want to treat the platysmus band that come oblique one and not the ones that are vertical, so this is important. So thinking about the different classifications that we have in the patient, I want to share with you some of the results that we have in each of the case. This is a case one. So this is real because I'm come from the Mediterranean where the sun exposure is very different than we have here. And so the objective is the skin quality. This is 8 weeks later after the treatment. We did PLLA in the patient, polynucleotides every 2 weeks. We did endolaser, morphosate, and a treatment that is for the skin. And you can see how we improve the quality of the skin in this patient. How we improve the mandibular line as well. You can see in all the photos, it still has laxity, of course, but it's much better than before. This is another patient, this is a male patient as well. This is the aged neck, and so we define more with reduction of the volume in the area. You can see how we can have more definition here, how we can have a reduction of the volume, and also in the mandibular line. So this is another of the cases that we can say that we have an improvement in this, and this 18-month follow-up between one photo and the other. And this is a patient, and this is more focused on the prethyroidea area. That is a very difficult area for treat, not surgical. And you can see how we improve the skin 9 months later after the treatment. So for me, the neck is more about the neck is cylindrical, so it must be approached holistically. So combined protocols increase the effect of the results in regards to both time and outcomes. And first, remember, reduction of the excess volume. Second, volume replacement. And third, collagen stimulation. Thank you very much.
Thank you so much, Dr. Pupo. Such a very great combination, comprehensive about the neck. So last but not least, I have Dr. Han Kin Chan from Hong Kong. Yes, Dr. Chan will also share us about treating the patient with melasma by IPL and collagen biostimulator.
Okay. Good afternoon, everybody, professors, seniors, and colleagues, ladies and gentlemen. We're at our last talk today, so we're going to go through this pretty quickly. I'm honored today to be able to present a little bit about my thoughts and results from my own Light to Lift protocol. So these are just my few disclaimers, and I'd appreciate if we don't take any photos of my patients. I'm currently practicing in Hong Kong, and I also earned my master's degree in allergy from Imperial College London. So before we linger too long, we'll dive straight ahead. Melasma, as I'm sure a lot of us here who are seated today have seen patients or treated patients themselves, and they think that, I'm sure most of us think that it's a very difficult case to treat, especially in Asian patients. And this is my aunt that I'm going to show you. I saw her in September 2023, and I treated her with a very preliminary version of my protocol. And after half a year, she was very, very happy. But obviously, this is not the end of the conversation. Even with continuous treatment that I'm taking care of her every week, every month, every week, she is still unhappy because the problem keeps coming back. What we see in melasma, especially in Asian patients, is that it's a relapsing condition. Even if she uses concealer or makeup, her pigment cannot really be covered. And so we know that melasma, especially in Asian patients, has a 40% prevalence in Asian women. There's up to 77% recurrence rate and a 9:1 female to male ratio. And this is due to Asian patients having a higher baseline melanin content, as well as a susceptibility to higher chances of PIH and higher melanin activity. We know that melasma has different numbers of triggers, with most people experiencing triggers with stress and UV and heat exposure. And then patients who enter this cycle of melasma, they go through a cycle of relapse with pigment, inflammation, barrier damage, then more pigment. Currently, with a lot of melasma protocols, we treat with topicals, oral treatments, EBDs, and peels. But conventional monotherapy may not always be successful. And this is because there is basement membrane disruption, dermal ECM degradation, as well as vascular dysregulation that we do not treat simultaneously. So what we do need is a multimodal therapy. If pigment and structure are both the problem, then both must be treated, which is why I came up with my Light to Lift study. And the study entails IPL and PLL-SCA, as a lot of my previous speakers have talked about already. The study included 8 patients who had recalcitrant moderate severe melasma. My primary outcomes were the Modified Melasma Area and Severity Index, as well as the GAIS and patient satisfaction. Let's quickly dive into IPL and PLL-SCA. IPL, as we know, uses selective photothermolysis and targets melanin and vasculature at the same time. This decreases VEGF and decreases inflammation, which leads to visible short-term pigment enhancement and vascular normalization. And this is demonstrated in previous studies, numerous studies across the world. But why is it not sufficient? Because it only treats the epidermis and not always treats the dermal component. With PLL-SCA, we know that it is a regenerative biostimulator that stimulates collagen 1 and 3, as well as basement membrane repair. In the end, what we get is barrier resilience. We also get progressive dermal remodeling and barrier enhancement, and this is also demonstrated in numerous previous studies. So I thought, why don't we combine these two and treat both at the same time? This is how I came up with a synergistic treatment of both the epidermis and the dermis using IPL and PLL-SCA. With that, we get pigment clearance, vascular normalization, fibroblast activation, dermal remodeling, and relapse prevention. And what we get in the end is we're not just treating melasma, we're teaching the skin how to remember how to balance itself. First, I'm going to quickly talk about why I'm treating IPL and then PLL-SCA. IPL definitely comes first, especially for Asian patients. In our culture and in our area of the world, patients value results, very, very quick results. They want to be able to see that this treatment is working. That's why we want to target the more superficial pigmentary and vascular drivers of relapse first and stabilize the skin. Then we can reintroduce PLL-SCA, which is a slower acting agent, often requiring months to actually see results. PLL-SCA helps to rebuild the dermal support and with collagen stimulation as well, improving barrier resilience, skin quality, and treatment durability. Now I come to my Light to Lift protocol, which is a 20-week protocol incorporating 5 sessions of IPL and 4 vials of Sculptra, or of PLL-SCA. At the end of this 20-week, we look at the patient again and tell them, oh, should we repeat this whole protocol again, or should we go into a maintenance phase? And this is very important why I chose a 20-week mark, because a lot of patients who are going through melasma treatment are going through endless treatments. They don't know when it stops. We just keep telling them, oh, we continue, we're trying our best, but results are still not there. So what's the benefit of telling them that, okay, we're going to put you through this at the end of 20 weeks, we'll see you again, and reevaluate what is going on next, because they feel that, okay, there's a marker, there's a goal at least, that they can make it to. And so we are able to allow the dermis to transition from an injury control to a regenerative signaling phase. And in my results, I found that 86.7% of patients receive more than 30% of MMASI reduction, and more than 46% received more than 50% of MMASI reduction, with a very high patient satisfaction rate. Patients also reported a lot of skin clarity, luminosity, texture, and firmness. And this protocol is really driven for Asian skin because of 3 main things: safety parameters, cultural preferences, and enhanced efficacy. We're very conservative with our fluence levels and wavelength, and we allow for maximum cooling periods between the IPL treatments. As well as what I highlighted earlier, we want gradual, natural appearing improvements that is suitable for patients who are in this locality. With higher baseline melanin content, we respond better to a dual modality approach. Obviously, echoing my previous speakers, we also need to have better patient selection. And what's more important than patient selection is also the aftercare. We always have to remind our patients to have realistic expectations and sun protection compliance. So in the initial stages, we offer visible improvement within weeks, and this helps to build the trust and doctor-patient rapport as well. And afterwards, we also have PLL-A, which helps to improve the skin quality overall. and this helps to stop any dropouts or any perceived failure in the long term. And I'm very excited to show some of my clinical outcomes, especially this patient. So we see over 6 months that the pigment over both of her cheeks, as well as on the nasal bridge, have significantly decreased. But what's more, her skin quality is also improved. Her skin texture is improved, some of the nasolabial folds, the volume loss, that is all improved. And so what frustrated me initially before I showed this patient her before and after photos was that she actually didn't think that she improved at all, and that her melasma condition was static. And that, I think, happens to a lot of us who are practicing aesthetic medicine. Our patients don't actually see the difference until we show them the before and after photos. And when I showed her this, she was over the moon. She truly believed that at least there was some result that she can go home and tell her husband about. Our next patient, we can see there's a focus of a very large part of pigment on the cheek, and after 6 months, this also greatly improved. We can also see some improvement in the volume loss as well as jowling. And in my next patient, there's a smaller focus. And I often find that with patients who only have 1 to 2 localized areas, that they actually focus a lot of their energy and time on this area, and they also do not think that there is a lot of improvement. And which is why before and after photos is so important, to actually show them there is improvement in the long term. And lastly, this is another patient who has less of a serious case in the beginning. And with less serious cases in the beginning, obviously the difference is not as much. However, as I said again and again, it's very important to reassure our patients that there is improvement along the way, not just in terms of pigment, but also in terms of overall skin quality. And so we go into the long-term success strategy of how we maintain patients and ask them to keep coming back so we can follow up and control their condition. I've proposed a maintenance protocol of an IPL session every 3 to 6 months and PLA-SCA touch-ups every 18 to 24 months, obviously as patients need. But the key success factors lie in realistic patient expectations and a commitment to maintenance. As I've said again and again, a lot of Asian patients, they've tried a lot of different modalities, and a lot of those modalities have failed in the past. And so what I want to bring with this protocol is a more realistic timeline that they can actually look forward to with a little bit of improvement. And so where does this protocol fit in actual practice? At least in my practice, I explain to patients that this protocol actually targets pigment, vessels, and the dermis. And in Asian patients, we have lower parameters with the IPL, which is a little bit more conservative, and the durability may be more improved. So the Light to Live protocol that I'm using currently on my patients already has 5 main branches that I always tell them about. First, it's comprehensive mechanism targeting. We're not just treating one single layer, as we were mentioning previously in our talks. We're treating 2 different layers at the same time. We're also using an enhanced safety profile because we know that Asian patients have a higher risk of PIH and relapse. And we're also introducing PLA-SCA as something that can actually help sustain results in the long term. This leads to natural and gradual improvement and is based on scientific approaches in all papers previously. And finally, my key clinical takeaways are that melasma is an epidermal and dermal vascular disease, and a dual modality approach is a mechanism-aligned regenerative and relapsing approach that hopefully may help treat patients toward longer remission rather than short-term suppression. Thank you.
Thank you so much, Dr. Chan. So this is the time for the Q&A. We have a little bit of the time at the end of our session. Too bad that Dr. Anand, due to her travel itinerary, she cannot join us. But any question from the floor? Of course, yes. Yes, we can do it right away.
My first question is for the
Yes.
first speaker, Dr. Terry. Thank you for sharing your results. So is there a particular thread that you prefer to use for your thread lift in your V-line contouring? A particular type of thread that helps with longevity, because there's multiple modalities of treatment. So I'm just wondering how it all combines and stays the way it is.
Normally, I have 2 kind of choice. One is the smooth PDO thread for the preaxial area, preaxial sulcus area, and posterior preaxial sulcus area. And the other is the barbed thread for the lower face and the mandibular, submandibular fat pad area to reject the fat pad. Yeah.
Thank you. And is there a maintenance protocol for how you would continue with the patients? Are there some sessions that you can continue throughout? Is there any recommendations on how?
Normally, it depends how much they spend.
Exactly. They're not going to do all the procedures all the time. So.
If, as I just mentioned, because we are executive doctors, so if the patient they have a tight budget, we can only proceed maybe a few treatment. But if they have unlimited budget, I will start with the soft tissue envelope first, and then do the filler for the second, because across, as you know, if you see on the internet, a lot of doctors nowadays they only do the fillers. So if you do the same, it's hard to stand out, and you must let the patient see the result, just like the doctor just mentioned, because you know Chinese patient is really tough and tricky. You have to take
Indian
less
patients
down
also.
time and immediate result. So we have to, do the different way.
Thank you
Yeah.
so much. May
Thank
I ask
you.
one more question
Sure,
to
definitely.
the last speaker?
Yes,
So
Dr. Shan, right?
Yes, thank you, Dr. Shan. So, in treating melasma, I'm just wondering, after you finish these sessions, do you still use any depigmentary inhibitors? Do you use thymidol, hydroquinone? Are you using any of that, or just wondering?
At present, most of the patients who are coming to my clinic are already, they've gone through all the topicals. So to be honest, I think that they've lost hope. So as a maintenance, even after the protocol, they don't use any topicals anymore. Yeah.
Thank you, that's good.
Thank you so much. But we still have a little bit of the time. Is there any question? Of course, I will not leave you alone. I have some question for you too. Yes, definitely. Yeah, anything
Because
to share?
with the IPL, you never experience any recidivate? Because I see with the IPL, some patients, because I come from Latin America, and this is something that we don't have in the first line of treatment is IPL, because a lot of patients react, the melasma react after the treatment, and also we approach the patient in oral, because there is a neural component in the melasma when the patient under stress, with the patient lack of sleep and that. And so I wonder if you never have any case of patient that after EPL, because you start just with the IPL, you say, and sometimes we can see that the melasma is getting
Yes.
worse.
Yes, it's quite a tricky machine that you are trying to say. Is there any tips from you that you
Absolutely
have excellent
correct.
results?
So one tiny trick that I use is I cool the skin first, significantly, with ice. That does help with controlling some of the overall temperature during IPL treatment, and obviously to use parameters that are definitely with more cooling.
What
in the
parameter do
future.
you use normally in the patient? What length do you
So
use?
I actually start off with a 755 nanometer filter, triple pulse, very, very low energy.
It's quite long, like
Yes.
755.
Very, very long.
Okay.
And then we work up to shorter wavelengths according to the patient. I think as well, another factor is all our patients who are coming to my clinic, they are a little more senior, so they have less stress to have to manage in their lives. And obviously, we do tell them that that's also a problem that they need to address, but it's not something that we can help with.
Yes, I also have elderly patients that are older. And also, I want to ask you for the PLLA, so do you use it in a concentration that is hyperdiluted, more focused on the skin, or do you use it just in the normal, regular dilution that they recommend?
What is your dilution?
I use a normal one,
Normal one.
as indicated on label.
Yes.
Yeah.
I also have a little bit of the point of concern also, since we all know that PLLA is quite acting via the inflammatory phase.
Yes, that's
So I also want to ask you, Dr. Shan, why you choose PLLA before other of the biostimulator that may be less in the inflammatory process?
Thank you for that question. So I'm sure there are a lot of different head-on-head studies that have been done on biostimulators.
Yes.
And I mainly chose PLLASEA because my patients, they want something that's more subtle. So compared to other biostimulators, in my experience, there may be a bit more of volume increase in the beginning that my patients definitely do not want. With PLLASEA, because of the dilution, patients are able to return to work, return back to home without being known that they have had any treatment. And that was one of the main concerns that I had.
Oh, in terms of melasma, is there any pros and cons between each biostimulator? Like, is there any beneficial for the PLLA?
I think there is more research to be done. in that
Okay,
area.
yes, agree. So Dr. Park, I will not let you alone. I see you evaluate a lot with your protocols with multi-layer and also ultrasound in the skin thickness. I think this is quite a really great way to do the follow-up. I would like to ask that about your protocol. How often do you do this evaluation with the skin thickness improvement?
I usually use the ultrasound with my patient, the skin layer thickness. I perform this kind of technique 100 patients in my clinic, my hospital. So I think every day I emphasize this kind of layer stimulation because even Korean doctors use many kind of solution with the
Too many.
Every time we consider about this, using what kind of product is more good for patient. Okay, and layer is more important. I think layer is more important because every result is not same, even the same patient. Okay, so protocol is important, and every time I use this kind of manual like this. Okay, so I found some significant result. So I wanna report this kind of the paper with Dr. Lee Kyo Ri.
Okay,
Kyo Ri. Okay, and I want to mention about more thing because Doctor told me told us about the PLLA and PLLA. And the next generation is I think many solutions are released, but the Kitosan or other kind of material is so much more important. So rapid change in South Korea. So even I can follow.
Yes, too many.
Too many.
That
Okay.
maybe we will wait for your publication, of
Okay,
course.
thank you so much.
We are big fans of you. So maybe we come to an end of our session, and guess what? This is the last question. So we are closing IMCAS Asia today. So thank you so much for your attendance, and of course, thank you all of the speakers. I think I can say on behalf of the Thai Cosmetic Dermatology Society, thank you so much for joining us, and see you next year. Thank you.